Welcome to Stanford Medcast, the podcast from Stanford CME that brings you the latest insights from the world's leading physicians and scientists. If you're joining us for the first time, be sure to subscribe on Apple Podcasts, Amazon Music, Spotify, or YouTube to stay updated with our newest episodes. I am your host, Dr. Ruth Adewuya. Dr. Fatima Cody Stanford is an internationally recognized leader in obesity medicine and one of the first fellowship-trained physicians in this field. She is an associate professor of medicine and pediatrics at Harvard Medical School and cares for patients at Massachusetts General Hospital. Dr. Stanford's work reframes obesity as a chronic relapsing disease and addresses disparities in care, weight bias in clinical settings, and the importance of early evidence-based interventions for children and adolescents. She has authored over 275 peer-reviewed publications, contributed to national guidelines, and advises organizations including the National Academies of Sciences, Engineering, and Medicine. A sought-after educator and public advocate, Dr. Stanford has been featured on 60 Minutes, The New York Times, and CNN, and she is deeply committed to advancing equitable, compassionate care for patients with obesity and training the next generation of clinicians. Dr. Stanford, welcome to the show, and thanks for being here.
Thanks so much for having me.
You've said on 60 Minutes that obesity is a brain disease. What does that framing unlock for pediatric care that a willpower model never could?
I'm so glad you started with that question because a lot of people have wanted to put the blame on individuals that have obesity. When we delve into the biology of this disease, we recognize that there is a lot of pathophysiology that starts in the brain. There's an anorexigenic pathway of our brain, and when we hear anorexia, we hear a pathway that tells us not to eat. And we have an orexigenic pathway of our brain, so a pathway that does tell us to eat. Those of us that are lean have an upregulation of that pathway that tells us not to eat. And those of us that carry excess adipose, which is fat mass, have an upregulation of that pathway that tells us to eat. And this helps us to understand that when persons carry excess fat mass, it's more than just you telling them to eat less and exercise more. This removes a lot of that blame-shame game that we have put on parents or children that carry excess adipose throughout their childhood and unfortunately will often carry that into adulthood. There's biology behind it. How do we then use this to treat individuals that struggle with this disease process? And this has been a lot of what I spend time with families to help them understand that I can be a part of the solution, recognizing that there's not just one answer to the question. It's a multidisciplinary approach to addressing this disease process, but the brain is at the center of it all.
That perspective challenges the old willpower narrative, and I can see how it changes both family conversations and treatment planning. How do families respond when you use this language compared to talking about it as a lifestyle disease?
Parents particularly are very receptive when you're talking to particularly a small child or even a young adolescent. They are sometimes confused by this, but you can imagine that this takes a bit of a weight, no pun intended, off of the family to recognize that they didn't just cause this, that maybe it was part of the epigenetic milieu. I can help them get to a healthier place. Yes, I do need them to go do some things. I want them to set up and frame a healthy environment, looking at healthy diet, lean protein, whole grains, fruits, vegetable, high fiber content, and set up a safe space for movement and activity. These are things that I want. But what if they've done those things? What if they've tried those things and aren't seeing any results? What can I then do to help change what's happening? One of the things that's great about the work that I have been doing, and not just me as an individual, but what I love is seeing the outcomes, seeing those pediatric patients become my adult patients and seeing how their life trajectory changes. I want to talk specifically about one of my patients that ended up needing bariatric surgery. Unfortunately, her mother used to take her to Weight Watchers meetings starting at the age of 4. Now, imagine a 4-year-old girl sitting there playing with her Barbie dolls in a Weight Watchers meeting. Is that the right place for a 4-year-old to be spending their time? I would say the answer is a resounding no. I would say that a 4-year-old should be spending their time being a 4-year-old. That 4-year-old went on to bariatric surgery at the age of 19 or 20, went on to become a nurse practitioner and works treating individuals that have obesity. But she was told that she would never be healthy. She was told that she would never conceive. She has 2 healthy young children and is caring for individuals that have obesity now. We can treat individuals. They can go on to lead healthy lives. Their disease processes associated with obesity can go into remission. But we don't have to be punitive in our care for these individuals. And this is what we've done to individuals that have had obesity. We assume that if we punish them, subject them to pain and blame and shame, we will make it better for them. We only make it worse for those individuals by not understanding the biology and the treatment modalities that may get them to the happier, healthier lives that would be best for them.
Such a powerful story, and it illustrates how framing obesity as a disease has the potential to shape somebody's life trajectory and highlights why clinicians can treat pediatric obesity as just diet and exercise advice. Building on that, what do you see as the most damaging misconceptions about pediatric obesity that you would like clinicians to abandon?
I really want us to stop thinking of this as the parents' fault in what they're feeding those kids. Notice how I said those kids. We look at those people as if they're like some dirty objects. Why can't we treat individuals with obesity with humanity and dignity and respect? It is entirely acceptable in today's society for us to treat persons with obesity, including our pediatric patients, as if they're second-class citizens. We are able to disregard them. We're able to choose not to give them dignity and respect. And I can remember, and I'm going to take you back to my pediatrics residency. In our pediatrics clinic, you could pick up the next chart, and whoever you saw would be the next person in our pediatric clinic because we weren't yet practicing physicians and had our own patient panel. If you had an individual that may have had obesity, you could skip that person, right? Because that was going to be a more complex person that had more chronic disease. So I would see my co-residents strategically skip those individuals that had obesity. What's the humanity in all of that? Why are you choosing to skip that chart? Is it harder work? Are there going to be more areas of discussion? Absolutely. If we go back to the question, what are we able to do? How are we able to just skip past or choose not to address? That's what I often see in some of my pediatric colleagues, even as we progress and become more advanced in our training and complete our board certification. Let's not address that, or let's move on to an easier, simpler case that brings us a bit more joy. I actually get the joy out of moving that person to a healthier lifestyle. Now, I'm going to take you to my most poignant pediatric case, a case that defined how I think about this entire field of obesity medicine. It was also the case that helped me get the American Medical Association to acknowledge obesity as a chronic disease and introduce you to a patient by the name of Twinkie. Think about why she might have been called Twinkie and let that resonate with you. So we're going to meet Twinkie, a young Black girl in South Carolina where I did my residency. I was an internal medicine pediatric resident. I was tasked with having Twinkie as a patient. She had made her transition from the pediatric ICU down to the floor where she'd come into the hospital with an asthma exacerbation. When I walked in to do my morning rounds, I noticed that Twinkie was not breathing. I went to figure out why Twinkie wasn't breathing, and I shook her. She did kind of gasp, choke for air. She then resumed breathing, and I said, probably Twinkie, who was around the age of 11 years old, has obstructive sleep apnea. I reported this to my senior residents and attending physicians, and they were like, good job, Fatima, acknowledging that she has obstructive sleep apnea. What she came in for was an asthma exacerbation. We need to make sure she gets her asthma training and get her prepared for discharge. We still had another day to arrange all of that information. And now that we have this new potential diagnosis of obstructive sleep apnea, get her set up for her discharge with a sleep study for that important diagnosis. Next morning comes as I do my rounds. Here she is, not breathing again. but we got to get her discharged because we got to flip those beds in the hospital. For those of us that practice clinical care, it's about turnover. We got to make sure that we have those beds reserved for those that need the highest security of care in the hospital. We get her discharge paperwork, do my duty. As the faithful intern, we make sure that she's discharged. Her sleep study is scheduled along with her asthma education. All of those things are done. And she's scheduled to have a sleep study in approximately 2 weeks, which is actually quite fast for those of us that know how long it can take to get these types of studies. Unfortunately, within just a few days, I get notification that Twinkie's no longer living. Cause of death, obstructive sleep apnea. And so when we talk about whether or not we should treat obesity, whether we should treat individuals that have obesity in the pediatric population, whether we should just focus on lifestyle, I ask you to think about Twinkie and whether I should be getting invites to 11-year-olds' funerals. As someone in their late 40s, I don't like to get funeral invitations for persons in my age group, let alone 11-year-olds who should still be around. When I told this story to the American Medical Association before their pivotal vote to acknowledge obesity as a chronic disease, I can tell you that for anyone who has any compassion or empathy for individuals, that it was indeed that story that convinced the House of Delegates that we should indeed acknowledge obesity as a chronic disease.
Thank you for sharing that. And what a heartbreaking, but also formative story that underscores how easily obesity-related complications can be overlooked when the focus stays narrow. And the fact that this case helped catalyze broader recognition by the AMA just shows how individual stories like this can drive systemic change. That brings us to this question of timing. The 2023 EP guideline moved away from watchful waiting and emphasized earlier, more active treatment. How do you think clinicians should balance that urgency with the sensitivity families need in those early conversations?
I'm going to go back to Twinkie. I think this story speaks to why watchful waiting can lead to premature death. We wait, patients die. This is the reality of what we see. Patients do indeed die. Unfortunately, many of the pediatric patients that I see in my clinic present with greater morbidity than my adult patients. Both have severe obesity, but the burden of disease much higher in my pediatric patients. Higher glucose levels, higher evidence of lipid abnormalities, worsened liver disease. They come in and I'm just supposed to sit there and look and say, oh, you know what? Maybe they just get taller and they'll outgrow this disease. The time for action is now. I was penalized as a resident, particularly on my pediatric side, for putting obesity as a problem list on my notes. But how can we not put obesity as a problem list when it was indeed the contributor to these obesity-related chronic disease risk factors? And obviously, my residency was far before 2023 when the AAP finally made this very pivotal decision to change the guidelines to say we can no longer watchfully wait and need more aggressive measures for those that carry a high burden of disease. What we do know, and every clinical study has demonstrated this, is that if we don't intervene early, these young individuals that have this high burden of disease have much more aggressive disease as adults compared to those that just develop disease in adulthood. Let's say I have a patient that comes in and they develop obesity at the age of 30. Compare that to someone that had disease at the age of 4. Imagine how great that burden of disease would be if we didn't intervene from 4 all the way until they finally present. The disease burden is so much higher. The risk of death is so much higher. We need to intervene so that we can have better outcomes. And unfortunately, we don't see that happening. Even when I'm doing consults with my pediatric colleagues and I offer very specific outlined advice, I'm only one person. And there's only so many of us that can actually do the high level of care. So if I give you an outline, my goal is to say, I need you to share the burden with me. There's only one me and so many others trained in the field, but if I can teach you and provide clear steps on how to move beyond watchful waiting to using other modalities and therapies beyond lifestyle modification, My goal is to make sure that you and your community are equipped with this information so that it doesn't have to funnel in to a very small cohort of individuals that may be trained on how to do this. My goal is to guide and teach so that you can then do that for the wonderful patients you care for as a clinician in your particular setting as a pediatrician.
That's a really helpful way to think about balancing urgency with sensitivity, and also a call to action for the healthcare team and clinicians to really think about this as not the responsibility for only a subset of clinicians, but a responsibility for all. It brings us to one of the newer tools in our toolbox, GLP-1 agonists that are now approved for teens. Where do you see pharmacotherapy fitting into pediatric obesity care? And talk about what are your non-negotiable criteria for starting? And importantly, when do you not start?
We know that GLP-1 receptor agonists are now currently approved for the treatment of obesity in the pediatric population. We can begin using them starting at the age of 12. These medications are currently approved for thinking about high potency medications like semaglutide, which are a once weekly injection we can use. And what's very interesting also, if we look at the clinical trial data and even data for patients that I'm seeing in clinic, we see that pediatric patients tend to do a little bit better than adults. Overall, if we were to look at metabolic and bariatric surgery, the kids always seem to do a little bit better than the adult patients. With regards to when we utilize these therapies, we would use these for patients that have maximized their lifestyle modifications. They have tried dietary modifications, tried physical activity modifications, and have maximized those therapies. Now we're saying, okay, we've tried to maximize those. Now we may need to utilize a GLP-1. Maybe they have glucose intolerance. Maybe their blood sugar is a bit higher than we would like. Maybe they're carrying some excess fat around the midsection and have what we call metabolic associated steatotic liver disease. There are a variety of reasons where these could be helpful. Often I find that the parents are more fearful of the needle injection than the pediatric patients. Their kids are like, hey, mom, I can do this, or hey, dad, I can do this. Then the parents are like, are you sure? With regards to the side effects of these medications, the side effects are exactly what we see in the adult population. Nausea is by far the most common side effect, affecting up to 40% of patients as we're titrating the dose of these medications. The key thing is making sure that the parents or caregivers of these patients are aware that these medications are going to cause nausea, particularly as we're titrating these. What I often do, particularly since these are pediatric patients, is give these medications on the weekend so they're not impairing academic performance or their school day. I don't feel good at school. Another key issue is constipation. Kids don't often talk about their stool patterns, neither do adults. This is something that you have to be very direct with kids about in terms of whether or not they're having normal bowel movements and things of this sort. We, of course, look at BMI percentiles. For pediatric populations, if we're above the 95th percentile, we've moved into children that have obesity. So between the 95th and the 120th, we're in that first category. 120th and 140th, we're in the second. And then anyone over the 140th, we've gotten into that really severe category of obesity. These patients, you're starting to watch them come down those growth charts. It's really interesting to watch these individuals that are responders move from the, let's say, 136 down to the 127th, down to the 115th, down to the 95th, and see that major shift when they go on these therapies and are consistent with the utilization. One of the key things, however, with the medications is making sure that they're maintaining their muscle mass. We don't really think about this because they're kids and you're like, they're going to retain muscle, but the medications do potentially cause muscle loss. How do you negotiate that? You want to make sure that they're active and engaged in some strength training. Absolutely. Non-negotiables for these are the exact same as adults. You don't want to use these in individuals that have a history of multiple endocrine neoplasia type 2 anywhere in the family, anyone with a history of pancreatitis, medullary thyroid cancer. These are patients that you would not use these medications in. But like adult patients, if they are responders, we will continue the utilization of these medications. However, it should be noted that children that are of reproductive potential, we do need to be using forms of birth control because there is a potential for birth defects, as noted in animal models, particularly rodent models and rabbit models. We haven't necessarily seen that in human models, but we do need to be thoughtful about that in our young ladies.
A lot of clinicians are looking at the STEP Teens trial as a reference point with impressive outcomes. How do you help families interpret those results in real-world practice, both in setting expectations, but also defining what success could look like in 3-6 months?
Instead of them just looking at 3 or 6, I give them a year-long process. If we look at the trial data, it really goes out more like 72 months. If we're not seeing any response in 3 months, maybe this isn't a good drug for you, and it's okay. Not everyone responds to every agent, particularly also if they're having significant side effects. Let's say the nausea is relentless and they can't even sit up and go to school or study, then this is also not the agent for you. But if we're starting to see some response without any of these side effects at 3 months, and that could be characterized by 5% total body weight loss, then we start to set expectations around that percentage of their total body weight loss. So comparing them to them and not them to someone else.
As you mentioned earlier, sometimes medications don't work and sometimes medications are not enough. Let's talk a little bit about bariatric surgery, which is still often seen as the last resort. What do we know now about its safety and effectiveness in teens, and when should it be on the table?
Bariatric surgery is still the best option for patients with severe obesity. I have utilized this as a therapy for patients with severe obesity for many years and has much more data than we do with pharmacotherapy. We have 20, 30 plus year data on individuals that have undergone surgical interventions in the pediatric population. If we look at Thomas Inge's data, the teen lab trials, and I can even pull from my patients that have gone to surgery 15, 20 plus years ago and look at that data. It's important for individuals that undergo surgery to know that this is a lifestyle change that we need to monitor indefinitely. If it's a sleeve gastrectomy, which is the most common procedure, versus a gastric bypass, which is the second, they're going to need to supplement for the rest of their life. They're going to need a multivitamin, vitamin D. They're going to need calcium citrate plus vitamin D plus vitamin B12 forever. So this means that you're also going to need to follow up and get labs tested to check for vitamin deficiencies. We're also going to need to let people know at the outset that surgical interventions affect both bone and muscle. There is also what I call the honeymoon period post-surgical intervention. What do I mean by that? In the first 12 months post-surgery, you are going to feel amazing. You're going to be losing weight, feeling great. But what you don't know is that there's a honeymoon period. It comes to an end, meaning you had surgery done in the abdominal region, but your brain hasn't recognized that surgery happened down in the gut. The brain takes over. Hormones in the brain start to reignite. Ghrelin, or key hunger hormone, starts to reemerge. GLP-1, not a medication because we all have GLP-1 inside of us, starts to go down. GIP starts to go down. Cholecystokinin starts to go down. Peptide YY starts to go down. When people look at individuals that may have regained weight post-surgery, they assume it's their willpower, they didn't do something right, when they don't realize that it was the hormones in their brain and the gut that start to reactivate, that starts pulling them back in the direction of where they were prior to surgery. Now, one of my biggest areas of research has been using medications as an adjunct to surgical intervention. So about 90 to 95% of my patients that are post-op are also on medications, where we can double or triple their response to surgical interventions. These patients may lose 30, 40, 50, even 60+% total body weight loss with the combination of medications and their surgical intervention. If you've never been told that prior to going to surgery, you just assumed you failed. So going back to that same thought process that you had before you went to surgery, here again, I did something wrong. I didn't eat well enough. The surgeon reinforces this narrative because you did something wrong. Here you had this method of last resort, which I hate that language. They don't realize that it was this lovely brain of yours that pulled them back, not because it was their fault. What I do to my patients is I inform them before they go to surgery, look, the honeymoon will come to an end. When that happens, we need to think about what we're going to add so that you don't succumb to the fate that many persons that go to surgery succumb to. This isn't your fault. The biology was so significant that we needed to send you to surgical intervention. So why do we think we're going to solve it all of a sudden with lifestyle alone? This is an important consideration. Even in my pediatric patients, because if they're going to surgery as a pediatric patient, we have a longer time to sustain these results.
You've highlighted very well how powerful and effective bariatric surgery can be. But what I also heard is the need for effective and comprehensive communication with the patients, preparing them for both the highs and the lows of it, which would be a game changer for how they approach their recovery. Not every patient has the same access to these benefits. We know that Black and Hispanic youth experience higher rates of obesity, yet they're less likely to receive treatment. How do you interpret these disparities, but also what should clinicians be doing differently?
What drew me to the field, particularly as a Black woman born and raised in Atlanta, Georgia, was because I saw in my community that particularly Black women, Black girls, were disproportionately affected by obesity. But when I saw the people that were actively involved in the field, none of them looked like me. Were they going to be as invested in understanding how to address this in the community, whether in the pediatric or adult population? I didn't feel as though that was going to be the case. Why don't we have access in Black and brown communities? Why can't we ensure that the communities that are disproportionately more likely to have obesity get access? When we think about pharmacotherapy and metabolic and bariatric surgery, we have to be thinking about policies that allow access to all of the things that I just mentioned and recognize that unfortunately there's barriers to all of those things when we think about these communities. If we don't have the clinicians that are willing to care for communities, then we're going to also face that barrier even if we advance the therapies. I practice at Mass General Hospital. Our catchment area doesn't include a lot of people that look like me, but close to 45% of my patients happen to be Black patients. If you look at my colleagues, only about 8% of their patients are Black patients. Why is there such a differential? Because those patients come seeking me. They know who I am. They seek me, then their family members. It goes to show you that if there's a clinician that someone identifies with, then they will seek that individual that provides the care to those underserved communities. We serve mass health patients, those that are Medicaid, lower socioeconomic position, our older adult patients. Patients identify with individuals, but we know that there's barriers to entry for clinicians. And we're seeing that taken away systematically for our medical students, residence fellows, our nursing students, et cetera, across the healthcare ecosystem. We know that there's barriers to having healthy living environments that allow those to have reduced allostatic load, which allows individuals to have a healthier environment where obesity doesn't flourish. These are really important conversations that we have to have if we think about wanting to tackle these different levers that contribute to obesity.
Your research shows that income and education can be stronger deciding factors than race alone in terms of access to benefits. How should that reshape the way we think about equity in pediatric obesity care?
We have to have it such that there's more money and more education. This is interesting, but let's look at one of the most highly educated demographics in the country, which is Black women. Somehow, the most highly educated demographic still has the highest obesity rates. There's a pull and a push. This is what brought me to the field because I was seeing women with 4 and 5 degrees still struggle. So I knew that there was more to the story. If you look at a lot of my research, you're seeing this income disparity. You're seeing this issue with people that have greater income be able to have greater access. But we can think of individuals that have great income who've always struggled with obesity. The story is much more complicated than that.
I agree with that. Another component is insurance coverage, which often lags behind the clinical need. If you could change one policy tomorrow, what would it be to improve pediatric obesity care?
It would be universal coverage with regards to healthcare. If we had universal access and clinicians that are willing to treat individuals with obesity, we could help address some of the disparities. Because some of my research has also demonstrated that even when we have equivalent insurance, that individuals that are from racial and minority populations still don't get access to the same therapy. We need to have clinicians that are willing to utilize such insurance to ensure that there is equity in terms of access, whether it be lifestyle modalities like intensive behavioral therapy, pharmacotherapy, access to GLP-1s, and bariatric surgery, and ensure that each of those are being equitably used to ensure that those that need them the most are actually getting access to them.
You've worn many hats: clinician, scientist, educator, policy advocate. And when I was reading this in your Lancet piece, you mentioned feeling the need to do 10 times more than peers to be recognized. What lessons have you learned that might inspire listeners who want to advocate for change?
Follow your passion. If you have a passion and a drive, you'll continue to move forward. My high school in Atlanta, Georgia, was named after Dr. Benjamin Elijah Mays, a famous educator and orator, one of the teachers for Dr. Martin Luther King Jr. And he says, strive to do whatever you do so well that no person living, no person dead, and no person yet to be born could do it any better. That's a really heavy lesson to live by, but it is how I live my life.
Thank you so much for sharing your expertise and perspective with us. This conversation has really challenged us to move beyond outdated assumptions, recognize obesity as a complex chronic disease that requires early evidence-based and compassionate care. You've given us some practical insights that we can all carry back to our clinical teams. To our listeners, we hope today's discussion helps you approach pediatric obesity with fresh eyes, renewed urgency, and strategies that improve care for every child and family. Thank you for joining us on Stanford Medcast. Thanks for tuning in. This episode was brought to you by Stanford CME. To claim CME for listening to this episode, click on the Claim CME link below or visit medcast.stanford.edu. Check back for new episodes by subscribing to Stanford Medcast wherever you listen to podcasts.